So welcome back to Voices in Health and Wellness. I'm your host, Dr. Andrew Greenland, and today I'm joined by Dr. Dwight Baker, a physician whose story is remarkable from both a professional and personal perspective. Dr. Baker has spent 4 decades in surgery, including careers in general, vascular and plastic surgery before transitioning into wound care medicine. But what makes his perspective especially unique is that he's also lived with type 1 diabetes for nearly 60 years. When diagnosed as a teenager in 1966, he was given a dramatically different outlook than the one he's living today. Now, 6 decades later, he remains active, healthy, and free from many of the complications commonly associated with diabetes. And so today we're going to explore what he's learned both as a physician and a patient, the principles that have guided his health journey, and how those same principles influence the way he cares for patients today. So with that, Dwight, I'd love to welcome you to the show, and thank you so much for joining me today.
Thank you. Pleasure to be here.
So perhaps we could start a little bit with your journey. Take us back to 1966, if you will, and tell us what it was like being diagnosed with type 1 diabetes at the age of 15.
Well, at age 15, I was, I guess you'd say, a fairly typical adolescent, teenager. And I started losing weight, drinking a lot of water and urinating a lot. And my mother said, we need to get you to the doctor. So at the end of the school year, she took me in and he scheduled me to come back a few days later for fasting blood sugar and a 2-hour postprandial. This was 1966. There were no finger sticks. There were no A1Cs. There were no insulin pumps. There were no continuous glucose monitors. And the outlook with a diagnosis of type 1 diabetes at age 15 was not very good. At any rate, I went back in, had the blood sugars done, was diagnosed, and this was a diagnosis made by my family physician who birthed me and took my tonsils out when I was 4 and fixed my broken bones until I was 15. And he said, he had tears in his eyes. He said, I'm going to refer you to an internist in Montgomery, Alabama, which was near our home, well, about a 2-hour drive. And he's very strict, and that's what you need at age 15. He's 65 years old, has had type 1 diabetes for 20 years himself. And I've sent other people to him that were like you, and they've done well. So the next day I was in Montgomery and met this physician who impressed me when I was 15 years old. That he just seemed so brilliant and so professional, and that was so impressive to me. And I can't really on this podcast quote everything he said the way he said it, because he was pretty aggressive and vulgar in his approach to me, but he wanted to establish a relationship of he was in charge and he was going to be very disciplined in my care. And for that today, I'm extremely appreciative. But during that visit, he also looked at my year-end report card that my mother had brought in. And I had all A's and Latin and everything and algebra. And he looked at those and listed them off. And he said, well, what are you going to do when you grow up, young man? And I said, well, I want to be a mechanical engineer. And I'd like to go to Georgia Tech or Auburn to become a mechanical engineer. And he looked down at me and he said, no, you're not. You're going into medicine. I was 15 years old. Well, he set me afire, and I dedicated my life to medicine and healthcare ever since that day. But also during that time, I heard from other physicians that my outlook was not good with type 1 diabetes. At age 15, at that time, if you were diagnosed with type 1 diabetes, you had a life expectancy of another 20 to 30 years maximum if you did well. And at that time, there was there was a lot of controversy about whether control of type 1 diabetes made any difference in preventing long-term complications, such as blindness from retinopathy, amputations, renal failure, and heart disease. But only one physician gave me any hope. And it was this mean doctor who I was sent to when he took over my care. He was only one, and he said, if you do every blanky blank thing exactly like a blanky blank tell you, you'll live a longer, healthier life than a normal human being without diabetes. So 60 years later, here I am at age 75 with no complications anyone can find by my ophthalmologist, who's a retina specialist, and by my cardiologist, who's excellent, and my general physician. I don't have any complications from type 1 diabetes. I have an A1C of less than 7.0%, and I've kept it that way. And tight control has kept me going. And it was in 1992, I think, when the first results of a long-term study being done to determine whether type 1 diabetes, long-term complications of type 1 diabetes were prevented by tight control of diabetes. And they pulled the results and showed that if you're under tight control for the first 10 years after diagnosis, you will not have the long-term complications such as amputation and blindness and heart disease and kidney disease. And it so happens that I went to this first physician, who I look at as my savior, for exactly 10 years, almost to the day after I was diagnosed. So that's my background about type 1 diabetes. And I'm thankful for every day I live, and thankful for my healthy health that I have. And I realize that why I have such health is this physician who took care of me initially for the first 10 years preached that tight control was achieved first and foremost by diet control. He taught diet himself. He didn't leave it to a dietitian or a nurse. He taught everything himself. He didn't trust anyone else at that time. And I look back today, and he was so far ahead of his time in his thinking and in his knowledge about diabetes and diabetes care.
Such an amazing and inspiring story. Thank you for sharing. So this obviously going back to 1966, and you've mentioned a lot about him talking about tight control. What did that look like at the age of 15 in terms of your day-to-day? How did you maintain this tight control from the advice you were given way back then?
The desire to beat the odds, the desire to prove people wrong, that tight control could prevent complications. Plus, it was the only hope I had. Tight control. So, it's a very good question to ask me, because why did I behave that way at age 15? I wasn't afraid. I wasn't afraid of this physician. I had tremendous respect for the physician, and he was the only one who gave me hope. So I listened to his every word and lived by it, and it's paid off.
Thank you. So if somebody was newly diagnosed with type 1 diabetes today in 2026, what advice would you give them? I mean, is it the same advice you were given way back then, or is it kind of morphed into something else for 2026? Where do you stand on this?
Well, I would first emphasize to them that diet is the best way, the first and foremost way to control diabetes. And then I would direct them to the latest technologies we have for controlling diabetes, which includes the automated insulin delivery pumps, the continuous glucose monitors, CGMs, and I would also emphasize that exercise is important. It's very interesting that the internist who took care of me in the first 10 years, was my hero, and who guided me into medicine, directed me into medicine, and took care of me, and the reason I'm here today, did not believe in exercise. He thought it was way overblown. And I cannot tell you how often I experienced hypoglycaemia, and still do, but not nearly so much now that we have the new technologies, because I refused to believe him about the exercise portion. I enjoyed exercise, I enjoyed playing tennis at that time. and I did a lot of running and jogging for a long time. I don't now. And I learned how to live with hypoglycemia. But the newly diagnosed type 1s today, of course, it depends on the age as to what I would tell them, but I would certainly emphasize to them that diet is the reason I'm here. Diet is the critical basis for control of type 1 and type 2 diabetes. And then I would explain to them how they're blessed today to have all these newer technologies, particularly the automated insulin delivery systems that are available.
So what misconceptions do patients commonly have about managing a chronic disease such as diabetes in your experience?
Would you repeat that question?
So yeah, what misconceptions do patients commonly have about managing a chronic disease such as diabetes?
Well, the honest truth is I'm a surgeon. I don't directly take care of patients with type 1 or type 2 diabetes, although I've been practicing wound care for the past 6 years. So I run into a lot of diabetic patients who are mostly type 2s or mostly adults. I think back to the time when I was 15 years old, even though 15 is being younger could help in a lot of ways. I think today that if I was diagnosed with type 1 diabetes at age 40 or 50 or 60, which is fairly unusual, or even type 2, it would be much more difficult for me to become compliant with diet and managing my diabetes. So I have a degree of empathy and sympathy for patients who I see today in the wound care clinic who have the diabetic foot ulcers and the poor control and are not compliant. And I get on to them a bit about compliance, but not too heavily, because I think about the fact that if I were diagnosed at their age instead of when I was diagnosed, I would not have the same habits ingrained in me that have helped me be healthy and complication free. So when you ask that question, it's an open-ended question that opens up a lot of different areas, because it depends on when the patient was diagnosed and whether we're diagnosed with type 1 and type 2. A lot of people don't realize the big difference between type 1 and type 2. And type 1 is an autoimmune disease, as we found out. They didn't know that at the time when I was diagnosed. And type 2 is related to some people call it metabolic syndrome and poor health habits.
Thank you. So you've been talking a lot about your personal journey, but could you maybe talk a little bit more about your professional journey and what drew you into all of this? I know your inspiration was the intern who obviously you had early contact with, but what about general surgery and then later plastic surgery? Talk to us about your inspiration and choice to go into those particular specialities.
Well, I'm not sure what led me. I am sure what led me into general surgery. I love to work with my hands, and I felt like I could best help people as a surgeon. Also, at the time when I chose to go into general surgery, I was thinking about going back to my small hometown of 5,000 in East Central Alabama, and I wanted to be a physician to everyone and handle all the problems. Probably I wanted to do everything except deliver babies. And to do that, I felt like I had to be a general surgeon first. And frankly, along the way, being a physician and a type 1 diabetic has led me to read a lot of different medical articles outside of the surgical realm, which has helped balance me and I think helped me become a better physician overall. But I started out in general surgery somewhat with that idea. And along the way, I was, during my training, introduced more to vascular surgery. So I did general and vascular surgery when I practiced. During the 9 years I practiced general surgery and vascular surgery, I also took care of a lot of ladies with breast lumps and breast cancer. And this was in the late 1980s. The plastic surgeons at that time were coming up with ways to reconstruct the breast in a lady after she'd been treated with breast cancer with a surgical mastectomy. And that fascinated me. And I'd always been told in my general surgery training that I needed to go on and do something more than be a general surgeon. I needed to subspecialize. So I went back to the Mayo Clinic in 1991, the Mayo Clinic in Rochester, Minnesota, and did a 2-year plastic and reconstructive residency to become a board certified plastic surgeon. And when I came out, my first 5 years, I was in with 2 others, and we did everything in plastic surgery. We did reconstructions, we did hand surgery, we did finger replants, we did free flaps at that time, and as well as cosmetic procedures. And slowly over about 5 years, I evolved into a cosmetic breast surgeon so the last 23, 24 years of my 28 years as a plastic surgeon, I was doing a lot of cosmetic surgery, particularly cosmetic surgery, the breast and the body. And then along came the bariatric surgery for weight loss, and now the medications for weight loss. So an awful lot of people come to the plastic surgeon for renovation of their body after massive weight loss. So that was coming along as I retired from the operating room and just devoted my time to wound care a few years ago. But I'd say that breast cancer and reconstruction of the breast cancer is what enticed me to make that major change from general surgery to plastic surgery. And I've never regretted it. I've loved every minute of it, the reconstructive and the cosmetic part.
Thank you. I mean, I'm curious about the sort of transitions in the different phases of your career, and I didn't quite get what was it that drew you to wound care rather than just retiring completely. What was the kind of switch for you at that point after having done various different specialisms within surgery to make that final choice into wound care?
Well, I also, as a youngster growing up, the physicians were all general medicine doctors, general practitioners is what we call them. And that evolved into family practice. And that's another reason I went into surgery, is when they started talking about family practice and changing the course of from general practice to family practice, the courses were, I was just didn't interest me. But I always looked at myself as a physician first, surgeon second, a plastic surgeon third, and still do. And I looked at the time when I was retiring from surgery and thinking, I'm not ready to quit taking care of patients. This is my life. I'm dedicated to this. I want to do this, and as long as God will allow me to do so. And what can I do? And my wife turned to me one evening and said, you'd be really good at wound care. I've always thought you'd be good at wound care. And I had 2 mentors a few years older than me that I looked up to in my residency and in my practice. One was an infectious disease specialist, and one was a general surgeon who was my partner in general surgery before I went back to plastic surgery. And they both said, and they were leaders in the field of wound care in my home state of Alabama, and they both said, you'd be great at wound care, and that's what you ought to do. So that's what I've done. I look at wound care as primary care for a surgeon. And as a surgeon, I always took care of wounds. And I feel like that's where I belonged at this stage of my life. So that's where I'm at. And the other reason is because of having diabetes, I can't open my shingle and say, hey, I'm an endocrinologist. I know how to take care of your diabetes, although I may be able to practically tell people more about the day-to-day ways of taking care of themselves and help them. How can I do that? And I can do that with wound care because a lot of what I see in wound care is diabetic feet, diabetic foot ulcers, a complication of diabetes. So that's how I got into wound care.
Thank you.
And frankly, I quite well enjoy that too.
Amazing. So what does your practice look like at the moment? Tell us a bit about your typical week. Who are you seeing? What are you dealing with? Where are you operating from or working from? Just tell us a bit about your practice.
Well, currently, I am not seeing patients. I'm medical director, collaborator for nurse practitioners in the wound care center where I work, but I took some time off for some hips. I had to have a hip replacement and recover from that. So I haven't been seeing patients in the last 3 or 4 months, but in wound care, I've been seeing mostly diabetic foot ulcers and venous stasis ulcers. Everything else was kind of like surgical wound complications, which, with my experience as a surgeon, I knew what to do. And but a lot of diabetic foot ulcers and a lot of venous stasis ulcers.
Thank you. So on the subject of wound care that you've just been talking about, how much of successful wound healing comes down to lifestyle factors, in your opinion?
I would say 90 to 95%. Yeah, I look at lifestyle as tight control of diabetes, following a diet that controls your diabetes and taking the medications. To me, that's lifestyle. Being active is lifestyle so that you're not overweight. It all plays into diabetic foot ulcers, especially. Venous stasis ulcers are a bit different in many ways, but in a lot of ways the same in the fact that venous stasis ulcers oftentimes occur in people who are on their feet, standing, not walking as much, but standing at their job for years and years. And as you remember, the veins have valves in the lower extremities to help avoid blood backflowing, and venous stasis ulcers occur from the backflow of blood, basically. So that's a lifestyle situation, but people don't realize that when they're working every day for 40, 50 years on their feet. And those who wore compression stockings or elastic stockings to try to avoid their swelling of their feet and legs are the ones who have less venous stasis ulcers.
And on that point, I was just going to talk about surgeons, because we all know surgeons are standing up for much of the time. Did any of that, did you do anything preventatively during your many years of standing up operating?
When I went back to do plastic surgery, I learned to start wearing compression hose or jolts, elastic stockings that were of good quality, excellent quality. And I've worn those as a wound care doctor over the last 6 years, even though I'm not standing in an operating room. I do a lot of standing. I do more walking now than I did as a surgeon. And it's funny, my orthopedic surgeon, who actually I've known since he was in high school, I went to him in Birmingham, looked at me, looked at his x-rays, and he says, you've worn your joint out standing in the operating room all those years. But I don't have much venous problem. It's because I wore those stockings for many years,
So on the whole thing of wound care, then, what are some of the biggest barriers that prevent patients from healing? We've talked about some of the preventative things, some of the lifestyle things, but are there anything else which prevents or slows patients' healing?
Well, again, I consider it lifestyle, but it's non-compliance with recommendations, because a lot of our recommendations are lifestyle recommendations. Elevation of the lower extremities, wearing the proper shoes as a diabetic, most of all, as a diabetic, watching what you eat and controlling your A1C to keep it below 7%. Exercise, all those things we talk to the patients about, but so many of them are not compliant, and so many of them, most if not all of them are in our wound care clinics with problems because of non-compliance of what people have told them already to do to avoid these complications. That's not true 100%, but it's our greatest, I think it's our greatest challenge in wound care is non-compliance by patients, and trying to get them to be more compliant and help them with that in any way we can. There's just no magic bullet for that, unfortunately.
I mean, do patients arrive later than they should do, or they are better now than they were about, presenting themselves early? And with that, what impact does delayed treatment have on their outcomes?
Oh, delayed treatment in wound care has all the difference in the world. If we get to them early, we can usually prevent further problems. And of course, all of wound care and diabetic foot ulcers particularly is related to trying to avoid major amputation. But yes, getting to the earlier you get to a wound of any type, anywhere, the better chance you have of getting it healed, and getting it healed without complications. On the other side of the fence, the patients who come in late are the ones who are usually the most likely to be compliant with their care in the first place. That's how they got there. And they delay and delay and delay. And as you may be aware, I'm not sure in Great Britain like here in the United States, but the socioeconomic part of it is tremendous. And I see it a lot in wound care. The patients can't afford the right foods to eat. Not only do they not know what's right and wrong to eat, they can't afford to eat the proper things. But there are ways around that. It's just, I've often said, since I went into wound care, I look up at the staff and I'll say, what we need on this staff is a social worker, someone who can help the patients get to the things they need on a regular basis. But the socioeconomic part is a tremendous part that I see in wound care.
Thank you. Now, you must have treated many thousands of patients over the course of your career. Are there any success stories that have particularly stuck with you that you always remember and recount?
There's one in particular. Now, as you asked me, it jogged my memory. And it goes back to my, I think it was my first year in practice in general surgery. In 1982, I was on call one evening in the emergency room, seeing one little emergency after the other. And I just repaired a laceration of the radial artery in the wrist in the emergency room. And the ER physician grabbed me and said, "Hey, could you look at this chest x-ray? I'm puzzled. This patient came in, stabbed in the chest, and I thought I needed to put a chest tube in, but I look at the chest x-ray, I don't see a line of where the lung is collapsed." And I look at it, and the first thing I notice is a pretty narrow cardiac silhouette. And I looked at him and I said, "Where is he stabbed?" And he said, "In the anterior second intercostal space." And I said, "What does your jugular vein look like?" And he said, "Jugular vein? Why am I looking at that?" And I said, "Where is this patient?" So he took me in to see the patient. And there was this large, very healthy appearing 32-year-old African-American gentleman who looked very muscular and athletic. And he had a single stab wound in the second intercostal space to the left of the midline. His blood pressure was at that point about 85. And he was talking. And I said to the nurses, I said, get me a central line kit and an empty 1,000 cc bottle that I can hook up an IV tubing to. And they looked at me puzzled. I said, get it now. This man's dying. When they got it to me a few minutes later, his systolic pressure was 60. And I put the needle down into the pericardial space and got blood back and put the central line catheter in, hooked it up to the IV bottle and set it on the floor. And immediately 1,000 cc's of blood came out. And the man's pressure went down to 32 systolic, and he was panicking. And then it quickly came back up to 60, 80, 100. In the meantime, I was out in the hallway grabbing the phone and calling the OR and said, I got to bring this patient up and open his chest and fix his heart. And they said, we don't have a pump. We don't do hearts here. And I said, I'm not going to need that, hopefully. So then I took him up with the catheter in, draining the blood, and opened his chest that night and repaired a laceration to the myocardium, left ventricle. And it was about a centimeter away from the left anterior descending artery. So he was close to not living. Mm. And he went home 5 days later. He had no insurance, and he was a painter. He had no insurance. And he never came back to see me, and I never sent him a bill, never paid me. And about a year later, 3 patients in a week came in to see me, all with good insurance from the same company. And they said, I always want to know who sent you. And they said, well, there's this patient you treated one time. And he said, you saved his life. And it go to no one else but you for my surgery for my hernia, one for gallbladder, one for breast lump. True story, not embellished, didn't make it up. First year in practice as general surgeon. And I would tell plastic surgery patients that and tell my nurses that when I was a plastic surgeon 20 and 30 years later. And I'd say, you know, that's what I did when I was a general surgeon. But as a plastic surgeon, I also touch a lot of lives. Because if I have a lady that comes in here depressed about herself and I do a surgical procedure on them and they come back 3 months later, smiling, wearing makeup, new wardrobe, and happy, I've made her happy. I've made her significant other happy. If they're children, I've made them happy to see their parents happy. And if they work, their coworkers, hey, she is a pleasure to work with again. I'm telling you, it's a great, great feeling to have to help people. And that's why I did what I did at age 15.
That is a fantastic story, a real heroic story. So I can understand why you remember that and you recount it. So thank you for sharing that one. So where do you see wound care and chronic disease management going over the next 5 to 10 years in your perspective?
The same place I see cure for type 1 diabetes, and the same place I see cure for a lot of other illnesses, stem cells. I think stem cells are being way underutilized in wound care. I don't know why. I don't know if it's because of cost. I don't know if it's medical economics overall. I don't know. But I had a lot of experience with fat grafting in my plastic surgery career. Some very, very successful stories. You're familiar with fat atrophy from steroid injections into the subcutaneous tissue space, I'm sure. Mm-hmm. And you come in and you see a patient and they've got a big divot in their contour. And I've taken some done some fat grafts on some people, taking a little fat with a needle from the abdomen and put it into their buttock area where they'd had an injection. Had a lady who had a facelift and had a steroid injection afterwards, and she had terrible atrophy. And I put the fat grafts in, and a few years later, she was talking to someone about having a scar from facelift, but she couldn't find it, and it was gone. And I attribute that to the stem cells that are in fat. People really downplay fat in the body, and they don't like to be fat, but they don't realize that fat contains a large supply of stem cells. They can do a lot of different things in the body. And I think that can be used in wound care. I've not had any experience with it directly, but you asked me where things are going. I think that's where things will go someday. And probably, I hope sooner rather than later, because you see dramatic improvements. Well, I see dramatic improvements in the fat grafting I've done in plastic surgery for contour deformities mainly.
Thank you. And speaking of the future, what does the future hold for you? I guess you're in no danger of wanting to retire anytime soon. So what are your plans for the future, professionally, career-wise?
Well, I've enjoyed being off and being at home with my wife, and something I've not been used to for the last 50 years. And I'm doing some consulting work for companies, and I'm finding that there are a lot of areas I could do. And I'm hoping maybe that I can cut way back on clinical care, although I still want to do some. I'd like to do more consulting and work at home, and have a little more time where I control my own time, because I've never had that luxury until now. Although getting over this hip surgery was not a piece of cake the first 2 or 3 weeks. It's getting better every day, but and I'm ready to go back and see patients now. But I'm looking at doing more part-time work, perhaps locum tenens work in wound care to see patients, and then do more consulting.
Amazing. Well, with that, I'd love to thank you so much for joining me today. It's been a really fascinating conversation. I think your perspective as both a patient and a physician is incredibly valuable, and I'm sure our audience can take away some great takeaways from the conversation we've had. So thank you so much.
Thank you.